I think we all know we're embarking upon an immensely complex process of change across the whole of an institution which is perhaps one of the most highly valued and respected institutions in this country, if not amongst public sector institutions across the world. In the course of 20 years, a number of things have been done that have resonated very positively with the public, most notably very significant additional investment in the NHS. Let me say, first of all, a few words about the board as a concept. This is the first time ever that a government has set up an independent board with significant responsibility for delivery of healthcare through commissioning, but done it on a basis that gives it statutory independence. There have been previous management boards and other experiments of bringing in outside advice and counsel and challenge. What's different on this occasion is that the board exists at arm's length from government. I want to explore with you what that means. First, it means that there is an arm's length relationship with the Secretary of State for Health. The Secretary of State maintains and retains the responsibility for the National Health Service and providing those rights which are secured under the NHS Constitution across the whole of the country. But we share with him the responsibility for promoting a comprehensive National Health Service. Secondly, what goes in the new legislation is the Secretary of State's former power to give directions. The Secretary of State's power is confined to issuing to us a mandate. And the idea with the mandate is that it will be issued with 1 year in prospect, but also with 2, 3, and perhaps more beyond. It will be revised annually, updated and amended. But the idea of the mandate is that it's not about process. It's not about different clinical conditions. It's about outcomes across the 5 domains. Outcomes relating to mortality, relating to acute services, relating to long-term care, relating to safety and relating to patient experience. That patient experience is the value around which the Commissioning Board is wrapping its complete attention. Because our mission is to try to bring forward an approach to healthcare which is clinically led but patient-centred. One end, we have a health service which I would suggest is relatively well equipped by international comparators to handle acute conditions. And at the other end, a health service that really is struggling with the needs of health inequalities, with a relationship with social care, with the third sector, and with local government. And our design of the National Commissioning Board is intended to ensure that we bring, in the appointments that are made to the board, some real insights into these different areas. In advising the government on appointments on the non-executive side, we have been very keen to try to bring in people with different backgrounds and different qualities, some from the third sector, like Kieran Devane, Chief Executive of Macmillan Cancer Support, who has joined us as an Executive Director. We will, with effect from next year, assume responsibility for the direct commissioning of primary care, and in due course for the renegotiation of the GP contract. We will, from the beginning of next year, from April next year, assume responsibility for specialist commissioning, direct commissioning of specialist services, and for some of the large London and other hospitals, that will amount to over 50% of their revenue. But then the foundation of what we will be doing is working with clinical commissioning groups. And their responsibility will be, through a clinically led structure, to provide patient care that is tailored to the needs of patients in their areas. This is a new model. This is not a top-down model. I see our relationship with CCGs as breaking into 3 principal components. The first is our responsibility to authorize CCGs. My sense is that from discussions with a number of CCG leaders already, there's enormous enthusiasm in many parts of the country, but by no means universal, and an eagerness to be set free and an eagerness to be allowed to get going. The next style of the relationship, I have to say, is a supporting relationship. It is not our job to tell CCGs how to do things. It's not our job to dictate process or to set targets. It is our job, of course, to transfer and translate to the CCGs the very outcome objectives that the government sets for us. Thirdly, we have a quasi-regulatory relationship with the CCGs, which is that in the event of default, we have responsibility to step in and take what steps may be appropriate to try to ensure that there is no damage or risk to patients or financially. But our whole approach to this is to hold back. Our whole approach is to be true to the rubric which accompanied the white paper before the legislation, which was about liberating the NHS. We do believe that there is here a remarkable opportunity to start to refit and reattune the delivery of healthcare services to overcome some of the obstacles to efficiency and to care that I have reported to me consistently across the country. Let me say then a few words about leadership, and I know David Nicholson this morning has spoken very much about that, but you deserve to know a little bit about my own background, which is that for the last 9 years I have been the head of University College London, which is very close to here. If you were to ever try to run a university on a top-down basis, it wouldn't work. It would suppress the innovation and the capacity for change and reform. It's often said that universities are deeply conservative institutions, and that's true to an extent. Conservative in that any action that one takes to disrupt that open and collegial and cooperative environment is doomed to failure. But it does seem to me that there are many parallels that are worth our understanding. But that secondly, there are enormous opportunities for developing a stronger relationship between universities and the NHS. I have a view about leadership which is that it's a process of service. It's a process of working through consensus. It's a process of working collaboratively and cooperatively. And never more have we required that than today, with an empowered set of clinical commissioning groups, with CCGs themselves having a capacity to operate collectively in a way which historically has not been a noted feature of primary care, with an opportunity for CCGs collectively to think through the future of primary care and the future of the relationship with hospitals. The new architecture is one of shared leadership, one in which the National Commissioning Board will not be issuing diktats. It will be monitoring and working closely with the system, with those parts of the system for which it has direct responsibility, and with the CCGs. You start with leadership, I think, through language and symbolism and values and culture. And we hope that by working with all of you and with all of our partners from the voluntary sector and from the public sector and from the private sector, we can do whatever we can to take advantage of the new opportunities that the creation of the board and the new architecture of the NHS offers us. Thank you.
Thank you.